Thank you. So, what Diane has discussed is essentially about the fact that we're operating within a westernized university system that is governed by logics of coloniality. It's a Eurocentric institution that, in the absence of interventions that seek to rethink and remake the university in the service of justice, of equity, of inclusion, reproduces white supremacy as the norm. So whiteness then functions as a set of practices which structurally are taken for granted as simply being the way things are, rather than contributing to us recognizing that these things come from a very specific history and these things are actively reproduced on a daily basis through our policies, through our practices, through our procedures. So, to say a little bit then about the question of impact, what I would argue is that if the culture in your field does not change, and that's really any field or any discipline, if it doesn't change culturally, if the values, if the beliefs, if the assumptions and judgments, for example, that shape who is seen as a good fit for the field, don't change, if who's seen as a legitimate knower doesn't change, if the types of knowledges that are valued don't change, the underrepresentation of students of color will continue. And we know without a doubt from the literature on diversity in healthcare fields that the absence of diverse healthcare providers negatively impacts patient care, health equity, and also science. So, to change then, what does that mean? To change, I would suggest at minimum means acknowledging the legacy of racism in the field. In medicine, it means acknowledging the legacy of racism in higher education. It means recognizing how implicit and explicit bias shapes admissions decisions, so program admissions decisions, for example. It means going out and actively recruiting both students and faculty because it means hiring more diverse faculty so that students can see themselves in their faculty, they can see themselves in their mentors, and a new diverse faculty also allows for new contributions to the medical sciences, so new ways of seeing and doing medical science. And in thinking about this, if you feel that as a field you don't have enough faculty of color as a whole to draw from, it means finding out why this is the case and finding ways to remedy this situation. From the perspective of curriculum, the status quo means that what students are getting is a clinical and classroom curriculum developed from a Eurocentric perspective, assumed to be designed for a predominantly white student body. And this is a student body that is then envisioned as our future healthcare professionals, as our future researchers, working with white patients. And when engaging with the care of minoritized populations, I would argue that too often this work is informed by a missionary savior perspective that objectifies those it claims to seek to serve. So that's to say then that the norm, coming back to this idea of norms, right? The universal student, the universal patient is assumed to be white, which has real material consequences for patients who don't fit this norm, especially since we know that the majority of study subjects upon which the majority of medical treatments are based are in fact white, have in fact historically been white. So in looking at this when it comes to curriculum, when I work with biology faculty, for example, one of the things that we talk about, which would seem so very basic, has to do with imagery in medical textbooks and the lack of images of women and people of color in these textbooks, and the ways in which this in fact contributes in significant ways to healthcare inequities when it comes to access to care, and again to both implicit and explicit biases. Finally, to say something about pedagogy. Traditional pedagogical approaches, I would argue, whether this concerns clinical or classroom instruction, fails to give students the tools, the analytical tools, I would say, and the skills to identify structural inequities, to first identify them, to then be able to question them, and then ultimately address the ways in which these systems of power impact delivery of healthcare services and ultimately health outcomes. So we're talking here about racism, sexism, homophobia, heteropatriarchy, capitalism, so on and so forth, right? And a critical pedagogical approach, I would argue, can provide these tools to students. So it gives them an opportunity then to also understand their own location, their own social location in relation to these issues, their own epistemic location in relation to how they understand these issues, and provides them then with tools, skills to develop a sense of agency, to advocate for justice, to work on what it takes and what it means to create the type of change that we're interested in for the purpose of justice, of equity, of inclusion. Thank you.